And then now I want to introduce Jacob Kriegel, who is a graduate of our biodesign program. He is a clinician. He's going to tell you about his background. He is a cardiac surgeon and took a year of his fellowship to come through our biodesign program. And he's going to talk a little bit about that program and then how they came upon this unmet need for various cardiac patients, and then the device that he has now designed and where that company is. And so it's a really great story. And it's my pleasure to introduce Jacob Kriegel.
Thanks. Thank you, Eric. So as Eric said, my name is Jacob Kriegel. I'm a cardiothoracic surgical fellow and a graduate of the biodesign program, which is just on the other side of this black drape. And when I moved to Houston for the biodesign program, I was hearing about pumps and pipes as a really just incredible opportunity, multidisciplinary, really everything that Houston has, very strong industries coming together to think about problems. And that's exactly what the Biodesign Fellowship does as well. It's a multidisciplinary approach, bringing engineers, entrepreneurs, and physicians to think about old problems in potentially new ways. So really life-changing for me, for my team, and for our company, and I'm excited to tell you what we've been working on and give you a little bit of a walkthrough. So today I'm going to talk about congestive heart failure, go into a little bit about the heart failure epidemic, what's going on with the disease clinically and in the country, talk about the heart as an organ and how it feeds the circulatory system. I heard some of the students talking about it during the break. Talk about what that looks like when the heart fails, and then some of the new areas of treatment that are going on for this space and how our company, Alleviant Medical, fits into that. So as I said, this really is an epidemic. Heart failure affects about 6 million patients in the United States. We spend about $35 billion each year treating it, and it accounts for over 1 million hospitalizations each year. And it's a disease of old age, so as our population's aging, these numbers are all growing rapidly. And by 2030, we expect to be spending about $70 billion treating this condition. And in addition to being common and costly, it's also a very morbid condition. At 5 years, we have a 50% survival rate, and at 10 years, that drops to only 10% surviving. So really a very debilitating, morbid condition. So before we talk about what heart failure is, just a couple of quick facts about the heart itself. It's my favorite organ. It beats 100,000 times each day. That's 3 billion beats over the course of a lifetime. And it circulates about 6 to 8 liters of blood each minute. And so for Houston terms, that's a barrel of oil every 30 minutes. And I would argue that humans have never created a machine with this amount of longevity, efficiency, and really that's quite a bit of cycles to do without seeing failure. That being said, this pump can fail, and we'll talk a little bit about what that looks like. So this is probably in most people's high school biology textbooks a review of the cardiac circulation. And this is usually how it's presented with a central pump sending oxygenated blood to your brain and your body and your organs that gets deoxygenated, sent back to the heart where it's pumped back to the lungs to get reoxygenated. I'm sure we've all seen this at some point. I think this is actually kind of a confusing way to look at it with this figure of 8 cloverleaf pattern. So I think it's actually better to separate this. Instead of thinking of the heart as a single pump, it's actually 2 separate pumps connected in series. So we have the left side and the right side. And even though they're one organ, they're really actually in totally separate parts of the circulatory system. So if we walk through this quickly, we have the left ventricle at the bottom of your screen, and that's supplying blood, oxygenated blood, to all of your vital organs. And that's the main pumping chamber. So when that's squeezing, it's generating pressures of around 120 during the squeeze, and it relaxes down to 80 when that heart relaxes. That drives that oxygenated blood through the capillary beds of all your tissues, where it collects on the venous side, the top left of your screen, at a low pressure system around 5 millimeters of mercury. There it goes into the vena cava, back to the right side of the heart, where you get another squeeze towards the lungs. And again, you see that little bump up of pressure, and then coming back through the low pressure pulmonary venous system on the lower right side. So that's the circuit. So when we talk about heart failure, we're almost always talking about left-sided heart failure, left ventricular failure, which is the pump at the bottom of the screen here. And this is what heart failure looks like. So there's 2 big flavors of heart failure. In the middle is what we call a normal heart, and you can see the V-shaped muscular cavity is your left ventricle. You can see a nice, healthy muscle, and that's what's doing the main driving pumping function. On the left is what's called systolic heart failure. So you can see that same muscle wall is thin, flabby, dilated, and that's usually the result of long-standing oxygen deprivation or a heart attack that eventually causes that muscle to just weaken over time and thin out. The other flavor of heart failure is to the right. We call that diastolic heart failure, and this is actually the opposite problem. The muscle is extremely hypertrophied and stiff, and over a whole lifetime of pumping against a high pressure, just like a weightlifter in the weight room, that muscle grows, and it becomes so stiff that it can't adequately fill with blood. But in either case, the pump is failing. So what does that look like in our circuit? So I think it's best to think about two different types of the failure, of manifestation of this failure. The first is the forward flow. So when that left ventricle fails, it doesn't do a good job of pumping blood forward into that system, and you can get low blood pressure. Now, instead of 120 over 80, we see 80 over 40. We call that cardiogenic shock. That's an emergency. And for these patients that have progressed all the way to that point, they actually need a heart transplant or a mechanical device that can circulate blood for them. But that's only about 5% of all heart failure patients that progress to that end stage. The majority of patients get into trouble here with a buildup of pressure behind this failing pump. So not a forward flow issue, but a buildup of pressure behind that pump. So rather than a pressure of 10, you could see pressures up into the 20s or 30s, and that pressure backs up into the pulmonary circulation and into the lungs. And so if we think of this problem, we have elevated left atrial pressure, which backs up into the lungs, leads to fluid accumulation, severe symptoms of shortness of breath, feeling like you're drowning, and that's what sends people into the hospital so many times each year. And right now, we try to treat this condition mainly here, using medications called diuretics or water pills that try to lower the amount of fluid in the body. And in many cases, those drugs are just not effective at relieving symptoms or keeping people out of the hospital. So increasingly, we're thinking about this left atrial pressure as a target. If we can lower that pressure directly, we may be able to reduce that fluid accumulation altogether and reduce some of the symptoms and hospitalizations of this disease. And so we're thinking of left atrial pressure as a target. And part of this comes from a hint from Mother Nature. So you've probably heard of people that are born with holes inside their heart. And usually we're talking about an atrial septal defect, or a communication between the left atrium and the right atrium. It occurs in around 30% of the population. Usually it's very, very tiny and doesn't cause any issues. But some people have larger defects that need to be closed, either surgically or in the cath lab. And what we've learned in the past couple of years with experience closing these defects is that sometimes we close them and we actually unmask heart failure. That all of a sudden we close that defect and you get a buildup of fluid in the lungs leading to shortness of breath. And what seems to be happening is we're taking away a decompressive benefit from the high pressure left atrium into the low pressure right atrium. And that led us to ask the question, well, if closing a hole unmasks heart failure, could giving someone back this communication reduce some of those symptoms? And that's exactly what people are starting to think about. So here again is our heart failure model. We have elevated pressure in the left atrium. And if you make a connection between the high pressure left atrium and the low pressure right atrium, you can lower that left atrial pressure back to a normal range with a minor increase in the right atrial or venous pressure. So two companies, which are in the pre-market stage, they're experimental companies, are doing just this by leaving a piece of metal inside the heart and artificially creating this passageway, joining the left atrium and the right atrium. They put this device in about 60 patients. 1 year later, the results are very impressive at relieving symptoms, improving patients' conditions, and potentially keeping them out of the hospital. So a very strong positive signal that seemed to be sustained at 6 months and 12 months. This is a scoring system that we use to estimate how significantly people are affected, and we see improvements at 6 months and 12 months. And then again, how far these patients can walk in 6 minutes, and they're walking longer and feeling better. So that's kind of the concept. But the problem here is that implantable devices in the heart have significant drawbacks. We know that if leaving a foreign body in the heart can cause implantation failure, blood clots, tissue erosion, infection, all of which could be a major complication. And so at Alleviant, we are developing a novel device that achieves the same physiological benefit without a cardiac implant. So we do that through a 4-millimeter puncture in the groin. Under X-ray guidance, our device is advanced up into the heart, and an expandable metal blade is deployed and used to create a precise connection between the left atrium and the right atrium. We remove a very precise piece of tissue, pack everything down, and the entire system is removed from the body. And the result is a decompressive shunt without a cardiac implant. And so we think that this is a low-risk operation that could really change the face of the disease. Almost always when we tell people this and talk to patients, we get this response. And that's totally valid. It's a little terrifying, as all new ideas are, but we think that there's a lot to be said here, that this could be a new treatment approach. Very quick, and then I'll wrap up. This is our first live animal study we did at Houston Methodist with Dr. Barker, who was here. We successfully used our early prototype to do just what we said, to cut out and remove a piece of tissue from the wall separating these chambers. And this is a contrast injection. You can see we inject the left atrium, and you can see that that moves through the shunt into the right atrium, showing that we successfully made that shunt. So a lot more work to be done here. We're still proving the underlying concept, and we're doing our live animal testing over the next year, and eventually we'll move into our first human studies. But ultimately, we hope that this is going to reduce heart failure symptoms, improve quality of life, and maybe keep people out of the hospital, which would be a major win for patients and for the system at large. So thank you.